Ladies and gentlemen, good afternoon, and thank you all so much for turning out to help us with our engagement on this very, very gorgeous day. So thank you very much for coming. My name is Fiona Sandford. I am Vice Chair of the board. Just to say that very sadly, our chair, Karen Hamilton, isn't able to be with us today. She's very sad about this because this would be her last annual review. So I'm stepping in and hoping to have a good chat with you. I have a short presentation of about 12-15 minutes. You have some notes there already. And we very much hope that we'll get questions from you from the floor, because this day is so important for us as part of our engagement with the public, which is absolutely key to our strategy. Just to say there is a live recording going on, so I hope people are happy with that. And that all questions asked today, either submitted in advance or from the floor, will be fully answered if we don't get round to them all today, and they'll be put on our website. So thank you for submitting those in advance. And also welcome to those online, I forgot to say that. So a few updates to follow. I have to work the technology, forgive me. Oh no, stick to this first of all. What I'm going to cover today is an update on our various forums. Our area partnership, our area clinical forum that helps us inform our strategy, a bit on what we're doing towards the clinical strategy and the overall strategy. What we've done to engage with the public, with you, to inform this, and a few of our achievements that we've had over the years, and of course the challenges that we face, that we all know that we face. One of the first things I want to do is to introduce to you our new Chief Executive, Peter Moore. Peter Moore joined us very shortly after our last review, so in fact he's been with us for more than a year, but he won't have formally met you. He's bringing with us really a lot of fresh eyes and enabling us to think about the challenges that we face. He has, we'll forgive him for this, he has come from south of the border with a career in both the NHS and in management of car manufacturing, but he's brought a lot of new ideas to us and is very much helping us look at how we face the challenges ahead. Peter's a keen cyclist. You might, if you see one of these feral cyclists zipping across the borders, it may well be our Peter, so try not to knock him down. But he is also getting out and about to meet as many people as possible and to meet all the times of community. Oh, sorry. Can you hear me all right? Yes.
Sorry, online.
Oh, okay. I'm sorry, people online. I'll try to keep it a bit closer. I just want to update you on a couple of our key forums, which is how we engage with our staff and with our clinicians and with our public. The first of these is the Area Partnership Forum. This is a key way that we engage with our staff to help us look at the challenges that we face and how we deliver those things. It has a very, very strong focus on staff well-being and keeping the staff fully engaged in what we do. A few of its achievements over the year, it helps us focus continually on a fair living wage accreditation, which we're pleased we've done. It has occupational health development, reinvigorating the Health and Safety Committee, looking at equalities and how we work fairly with everybody, and continuous improvements for how the staff feel about how they work with us. So my thanks to everybody involved with the Area Partnership Forum and the great work that they do in the interests of our workforce. So thanks to all of them. The next forum I just want to touch on is the Area Clinical Forum. This you may not have heard of, but it's a very important way that we engage with all of the clinicians, not just in BGH, that we engage with clinicians in the community, with our GPs, with our dentists, with our ophthalmic specialists, with health scientists, and with midwifery, and with all allied professionals. And it gives us a very strong clinical voice of all of these independent practitioners who deliver so much of the care in the community that we all rely on so much. We've just appointed and elected a new chair, Paul Williams, our Associate Director of Allied Health Professions, and he has just been elected as chair of this, and we look forward to working with him to improve our strategy. A little bit about our strategies and deliverables. Our mission is really important to us, that we want to be ambitious, encompassing a comprehensive approach from prevention to specialist services and everything in between. We want to focus on quality, performance, people, finance and infrastructure, and working with our partner organisations. And that gives us really the bedrock of the strategies that we're going to deliver in order to deliver better healthcare to everybody in the community. We've had a lot of engagement with you, with the public over the last year. I hope you've come across some of our teams in supermarkets, in libraries, to ask questions about how we develop our strategies. And we're quite determined to focus on right care in the right place, and that we do enough on prevention, on primary care, a community service, on care outside the hospital bed, so that people are treated in the right place at the right time for them. So how do we do that? Well, this is really about how we've engaged with people and with the staff. This was January last year, where there were 51 engagement sessions all over the borders, run by Claire and her team. And I think you went everywhere, didn't you, Claire? To supermarkets, libraries, the hospital, the various health services, asking 5 key questions of everybody of what was important to them in how we delivered the health service. We've then gone on to develop our clinical strategy, and we've spent the last few months engaging with our clinicians in the hospital, our clinicians in the community, and we're about to publish our clinical strategy that will inform the rest of the organisation. And we really look forward to coming back next year to telling you much more about that. And again, the key focus is right care in the right place at the right time for people. So just moving on, really a little bit on this buzzword, social compact. This is really a compact that we have with everybody, because we're all in this together, delivering healthcare in the right place, maximising the improvement that we do, very much with a focus on listening to everybody in the community, listening to our patients, listening to the community, making sure that we listen to all voices delivering healthcare, everybody, the consultants, but equally the hospital porters, the nurses, the healthcare support workers, the school nurses, because they all have very clear ideas about how we can meet the challenges and get better at what we do. So listening to all our staff is really very important to us. A little bit on the challenges that we face. It's no surprise to anybody that the health service faces daily challenges, and a huge thanks to all our staff for the work that they do to keep us going. We know that our urgent and unscheduled care wait lists in the emergency department are longer than we would like. But we really are working very hard at that, and we are seeing improvement in the emergency access standard. And we have just had some 3.4 million additional funding from Scottish Government to help us take better care of our elderly and frail community, so that we get a faster flow through the emergency department. So we're just opening a new frailty assessment unit at BGH. And we're establishing a dedicated discharge team to speed up care planning, because we know that flow through the hospital is one of our biggest challenges to enable us to get the right care in the right place. We're also expanding, I think this is a really exciting thing, we're expanding Home First where we get people to stay at home for as long as possible and we treat them there, and hospital at home, where we can use get clinicians to help look after people in their own home rather than the need to come to hospital. And we are expanding both of those services. And I think that really is very exciting. We are already seeing through these various measures a significant improvement in the number of people who are delayed too long in hospital, which is never good to be stuck in a hospital bed when you should be at home. And we are seeing improvements there. And I'm sure the team would be very happy to talk more about that later. Now, we get our very fair share of compliments of the kind care that people receive when they're in hospital with us, but we also inevitably and rightly get challenges and we get complaints, and that's quite right. And our complaints department work really hard to make sure that every single complaint is dealt with as thoroughly as we can. We know that right now we're slower than we would ideally like to be in dealing with these complaints, and for that we're sorry. But we are working hard to listen from and learn from each and every complaint that's made to us. We are pleased that you may know that in Scotland, Healthcare Improvement Scotland can do a flying visit, an unannounced flying visit to any healthcare setting. And they came to us completely unannounced on the 5th and 6th of August, a complete surprise to the team, in they came. So we were really very pleased at the report that we got from them. They saw that our staff were treating patients with kindness, compassion, and respect. And they were pleased to also see that important areas like hand hygiene, the use of protective equipment to reduce infection, the management of patient meal times, especially for those who require assistance, all of those were being dealt with sympathetically and properly. There's still stuff we need to do. And of course, they found out stuff that we still needed to do, and we knew about them. I mean, some areas, like if you've been in BGH lately, replacing flooring, basic things like that we need to do. More safety in non-standard care areas, and we are working to do those. But we are, as you all know, a small, limited resource with a small team, but we're doing our best to overcome these challenges, and we'll be happy to update you more on those. But let's draw to a close on a much happier note. We're really, really pleased that our staff have been awarded by external people throughout the year. Rona Morrison up there was the People's Choice Award for Quality, and she's the Quality and Improvement Facilitator at NHS Borders. So that was a huge award for her. We were absolutely thrilled to be given the, wait for it, Golden Hip Award by the Scottish Hip Fracture Audit Group, recognising us as the best performing health board in Scotland for hip fracture care. So that was very nice to get. And then we've had the Scottish Health Award finalists. This has just been held last week. We had 3 finalists. We had Neil Jackson, psychiatric liaison nurse for care for mental health. We had a pharmacist in the final, Alex Mundell, and a support worker award with Vicky Gray. And we're delighted to say that of those 3 finalists, well done to all of them, but Neil Jackson, psychiatric liaison nurse, won the Care for Mental Health Award. So that was great. We also have received the NHS Scotland Pastoral Care Quality Award, recognising our commitment to supporting internationally recruited staff, celebrating best practice and ensuring safe arrival, induction and ongoing well-being of staff that we recruit from abroad. British and Irish Orthoptic Society awarded Trudy Logan a Rising Star Award. And the Special Care Baby Unit was named Team of the Year by the Scottish Neonatal Nurses Group. And last, by no means least, very importantly, Lisa Blackwood has won the Scottish Learning Disability Nursing's Network Award for innovative practice in care of the Learning and Development Service. So that's really an amazing list of awards. So we know that sorry. Performance achievements, you have most of these in your handout here. But we are pleased to say that we are making progress with waiting lists. Our ambition is to ensure that nobody waits more than 52 weeks for treatment. And we are completely confident that we will hit that target within the next year. So the waiting list size is falling. We are getting through planned outpatient waiting times, and cancer care, which was a worry in the last year. We always were very proud of our cancer care statistics. Our 24-25 waiting times for cancer care declined from 89% starting their treatment within 62 days of being referred to 70% in the 74-75. That was very largely due to a significant increase in referrals for suspected prostate cancer. So you'll be aware there was a lot of media coverage of that. It's clearly vital that we improve this, and we have a lot of initiatives going on locally and with our colleagues in Lothian that we need to deliver more complex cases. And I'm pleased to say we are seeing an improvement. I think we got to 74% of patients being seen at the right time in July. So, but we know we have further work to do on that. We were very pleased to be awarded our primary care improvement plan. We were given a national demonstrator site in the Borders to work this through, to help our colleagues in primary care deliver more effectively and deliver better services. And we've been working with the pharmacotherapy service to ensure that we get the right prescription to the right people at the right time. And most recently, we've expanded community treatment and care throughout the Borders. And there is now a central service that will book these various ways of treating within primary care. So phlebotomy, for example, you will be dealt with more centrally, but still in your local place. We know that delayed discharges are such an important thing to get done. I've already mentioned those, and we are seeing really good practice in that and really good improvements. So we look forward to telling you more positive stories later. So we know that we've still got a lot of work to do. We thank you very much for your involvement. We very much hope that you'll have questions for us, because that's what we're here to do. We've had some questions submitted in advance, and all questions will be answered on the website in full. But that's all from me. Thank you all very much for listening. Before I open the floor to questions, I'm going to ask the team to go around and introduce themselves so that you know who's answering your question. But thank you all very much for listening. Over to you.
Okay, thanks very much. Hello, everyone. My name is Peter Moore. I'm the Chief Executive.
And I'm Sarah Haran. I'm the Director of Nursing, Midwifery and Allied Health Professionals. Good afternoon.
Hi there, everybody. I'm Andrew Bone. I'm the Director of Finance.
Hello, I'm Lynn McCallum. I'm Medical Director. Afternoon, I'm Sohail Bhatti, the Director of Public Health.
Hello, everybody. My name is Gareth Clinkscale. I'm the Interim Director of Urgent Care Community Services and Mental Health.
Hi, good afternoon. My name is June Smith and I'm the Director of Planning here at the board.
Hi, good afternoon, everyone. I'm Oliver Bennett, the Interim Director for Acute Services, which essentially is the BGH.
Hi, I'm Laura Jones. I'm Director of Quality and Improvement. Hi, I'm Ailsa Patterson. I'm Deputy Director of HR.
So, ladies and gentlemen, has anyone any questions that they'd like to raise? Hello. Would you like the mic? No. Oh.
Hi, good afternoon. I'm Peter Donnelly, resident of West Linton. Thank you for a very clear
presentation and for outlining a number of local initiatives which sound very welcome, particularly the hospital at home initiative, which I think is an excellent idea. My concern is whether such welcome local initiatives will be sustainable if NHS borders were to be amalgamated with another health board. And the reason that's at the top of my mind at the minute is that I notice that NHS Lanarkshire have advertised their chairmanship. NHS Teesside have done the same. But despite the fact that your long-serving and successful chair announced her retirement quite some time ago now, unless I have missed it, I don't believe I have seen your chairmanship advertised. And I hope I'm putting 2 and 2 together and making about 16. But I guess I'm looking for reassurance that there is not a plan to merge NHS borders with another board.
Can I start to answer that? You're right, it hasn't been, the post, Karen's post has not yet been advertised. I think this is largely due to quite a blockage in the system of public appointments when they had a large number of different chairs to fill. I had already said that I would be content to be interim chair, so it's not being left blank. But it is my understanding that the intention is to advertise the post in the new year. I don't know, Peter.
Yes, thanks very much. So I think it's a really good question. Firstly, I'd say if you can add 2 and 2 and get to 16, then you've definitely got a job in our finance department. I think in terms of the structure of the boards, there's definitely no plans afoot to have any statutory mergers of organisations. We are currently going through a description of our clinical services, and we're developing that in our clinical strategy. And a really important element of that is for those services which are tertiary, either as in very complex services, we are looking to increase how we will collaborate with other boards in doing that. And the rationale for that is that some of the resources that we have across Scotland are really scarce, and we've got to work out how we make sure everybody across our population has equitable access to the right services. And that shouldn't be if you live around the corner from a tertiary unit in Glasgow or Edinburgh. It means if you've got a tertiary unit requirement or for really specialist care and you live in Hoyk or somewhere geographically further away, then there needs to be absolutely equitable access. And that goes to the heart of how we want to approach our work with all of the boards and through our partnership with them.
Thank you. Great question. Any other questions? Hi.
I wonder if you could just summarise for me what facilities patients who've been treated at home have. I've heard of hospital at home. I know about domiciliary visits. I know about health visitors. But how is all of this sort of integrated and organised?
Great question. Thank you. I'm going to pass to Sarah.
Thanks. Yes, you're right. And really about 80%, actually up to almost 90% of all care is carried out at home or close to home in a community setting. We do a small amount in an acute hospital, but the vast majority of access of care is not within the hospital. So there is a lot, and there's a lot of changes. And some of the names that Fiona's described there around hospital at home and home first, they do sound very similar. Essentially, what we want to do is have this delivered as a kind of one-stop shop. So if you need something, that this will then would run through a community basis, and whatever you need is decided in the community and delivered to you at home. So that really is effectively, it sounds very simple, but obviously underneath that it's very complex. We have domiciliary visiting, that's essentially district nursing, health visiting that everybody understands. Things like hospital at home, which is care you would only really get in hospital, delivered at home is new. Home first is around reablement, so if you've been in hospital, it's getting you home very quickly, and the therapy and care and support you need delivered at home. but then allied health professionals, healthcare support workers, registered nurses. I think from a hospital at home perspective, I'd quite like to maybe invite, if that's okay, to ask Laura Jones, who's the director who's taken responsibility around developing that, maybe just to flesh that out a bit, because it's a bit more of a newer concept for people, if that would be helpful. Thanks. So just to talk a bit about hospital at home. So we started with 10 beds last year to test whether that was going to be something that we could deliver for our, I'm conscious of speaking to people behind here, so I'll stand up. Would that be a viable model for a remote and rural area? So we've had to adapt that quite significantly to fit a remote and rural population. So we're at 20 beds today. We're moving towards 25 just after Christmas, and moving up to that will allow us to expand out to the further parts of the borders that we haven't yet been able to touch. So expanding that to total population coverage. We're also testing out some really exciting new technology as part of hospital at home. So remote monitoring kits that would allow us to keep younger people at home as well, who at the moment are often stuck in a hospital bed and not able to be in the creature comforts of home, but would allow doctors and nurses to care for them in their own homes. So this is a really exciting thing for us, and I think something that will firmly stay in the borders. We've demonstrated the success of that, and in fact we're aspiring to build that even further in the future.
Yes, it does, and I'm so pleased to hear that, because I personally had an experience whereby I was asked by a surgeon in Edinburgh who had operated on an eye patient, and this patient had had to go home. He was a terminal cancer patient, apart from having a severe eye problem, and he had to be followed up within a certain time. And there was going to be absolutely no way of doing this. He couldn't get into a vehicle, ambulance or anything, unless someone visited him. So I took it upon myself to do a home visit. Now, I was ordered not to do a domiciliary visit because that was not within my range. So I disregarded that order because I felt it was in the patient's best interest if I saw him at home, which I did. So there's some, it's a grand plan you've got, and I hope it works well. But sometimes there are little gaps. This is not a formal complaint, but it's just watch out for the little gaps.
Can I just say on the back of that, I think when we come to organising our services, obviously the services that we organise within the Borders General Hospital, it's fairly straightforward for us to understand the impact of those. It's far more challenging for us to do that for community services, and therefore they need to be done in partnership. These services need to be done in partnership with the population, the patients that the service. So the feedback that we get is going to be vital. The more feedback that we get, the faster we can make sure that these are really effective, and that the gaps that you've just identified there, they're absolutely the types of feedback that we need to make sure that we can then close as many of those gaps as possible, because the implementation of these services will be a journey, but the more involvement and the more engagement we have and the more we view this as a partnership, then the faster that journey will take. Thanks very much.
We're all having a go. And Robert, I suppose the other thing I would add to that is that what's really critical in this is that we listen to our staff, and what they're telling us is needed in terms of how we deliver this safely and effectively, as well as patients, as well as the public. You know, this is a proper engagement process that we're undertaking, and Fiona's referenced the clinical strategy, and you've been involved in the clinical strategy conversations this week, and what we're really hoping to do is to roll out services that our clinicians tell us are the right direction for us as an organisation. So this isn't about, you know, me as medical director or Sarah as director of nursing or Peter as chief executive saying this is where we're going. This is about our clinicians, about our public telling us what is needed within the borders in order to be able to deliver a safe and effective service. So as Peter says, that story is really critical for us to understand. And I have to say, I commend you for ignoring the the advice that you were given.
So that's public.
Yes. Any other questions, colleagues? Yes.
So I'm Tracy Virchowick. I'm Royal Biology Service, and we obviously support people in the community across the Scottish borders, but we also are part of the third sector here as well. So one of our missions really is about helping hands and helping people in the community. We were more focused to older people, but we are working with 18 plus now. So there's a shift in how we're working. But my question really here, and there's some good initiatives that are coming forward, but how is there an opportunity for us to connect as the third sector? And mainly one of the things that we really do look at is how we work with people earlier on, because we're getting people later and it's more difficult, it's more complex. And it means that we don't always give them the best quality either, because the complexities of their health needs outweighs what we can support them with. So my question really there is about the opportunities to strengthen early intervention and community-based support pathways.
Great question. Thank you so much. And I know that everybody's going to be bursting to get in on this, because moving to preventative strategies is absolutely key to the work that we're going to be doing. So who would like to start?
Thank you. Is it Tracy? Yeah, Tracy, thanks for that really, really important question. Lynn will talk about very similar things to myself here, I think, around our clinical strategy. One of the key things that's come forward, which I think we knew, but probably haven't paid enough attention to, is the work of the third sector and how we work really, really closely together for the good of the citizens and the borders. So you're absolutely right. And actually what's come out really clearly from the clinical teams who've participated is the need to work closer and understand what's out with the third sector and what you can do. And I can't agree any more around early intervention. That's at any age. It doesn't matter what age you are. The sooner we can intervene and actually prevent and enable people to pay attention to their own needs, their own health, their own environment, the better. Once things fall, you could argue, into a health sector, we might have missed the opportunity. In fact, we have in many occasions. So really vital. It is part of our clinical strategy and part of the engagement with teams like yourself. It's going to be really important and is part of our plan as we move to the implementation. I'll invite Lynn just to speak a little bit more around that.
Yeah, I don't have an awful lot to add other than to say and to try to provide the assurance that that multi-agency approach has been a really common theme through all of the specialties that we've spoken to and all of the clinicians that we've spoken to. So there's no question that the next 5 years will definitely involve active engagement across multi-sectors, including our local authority, education, but really critically the third sector. I think we recognise that there are lots of areas that precede ill health that are really important for us to focus down on. So if I give you a really simple example, social isolation, is a really, really significant risk factor for future ill health. And so, us impacting upon that, us wrapping around and trying to support that, and that's not an insignificant problem in the borders. We hear from a lot of people around the fact that they've become very socially isolated, particularly if, for example, for health reasons, you lose, for example, a driving license, and you're in a rural area, and the ability to be able to reach out and have those social networks is really critical. So I think we are very focused on that. If I can provide some assurance around the conversations that I've heard over the last 5 months in developing the clinical strategy, and certainly, it will be a key focus as we move forward.
I was just going to add the final bit to that. So thanks very much for the answers. But I think part of our, obviously we're describing a clinical, an architecture for our strategies that has the clinical strategy front and center, but then there's a set of enabling strategies and plans that sit beneath that. And one of those is our partnership strategy. And at one end of that partnership strategy continuum, we feel like is the need for us to have partnerships as an anchor organisation with big organisations, with the council, etc., and employers. But then that continuum will obviously go then through, I guess, through the third sector and voluntary sector organisations. But it ends with the partnerships that we have with our patients, and that, I suppose, answers back to the questions about how do we continually improve our services by making sure there's a continual dialogue. And if we go back to the conversation and the engagement events that we described last January, that wasn't a conversation to have. That wasn't the start of a single engagement event that we would then have, and then we'll come back and talk to people in 5 years after we've delivered this strategy. It's the first in a set of annual conversations, because we need to keep that conversation going, really. Thanks very much.
Thanks, and great question, Tracy. Thank you. Any other questions? Here we have one here.
Hi, thank you. Really just to follow up with what Tracy said there. My name's Sarah McGowan and I work in the wellbeing service for NHS Borders. So we're out in the community, we're supporting patients with lots of different factors in life, and like you said, isolation can be one of those. And we signpost a lot of patients to third sector organisations. So I know the board here have spoken about the sort of larger scale, but maybe I could offer you to come along to one of our team meetings and have a chat and how we could engage with you that way on the ground as a starting point for you. So probably in the new year, I think our next team meeting is quite busy, but maybe in the new year you could come along and let us know a bit more. Okay.
Brilliant, networking live. Thank you for that. Any other questions? Oh, hello. Hi.
Hi, I'm Jacqueline Ritchie and I also work for the voluntary service and I'm the transport coordinator for the Scottish Borders. I would like to ask what criteria processes are used to assess patient eligibility for NHS transport, particularly on the Scottish Borders, but not just in the Scottish Borders, or when you're sending anybody for appointments out with the Scottish Borders as well.
Good question. Can I ask Andrew Bone to answer?
Yeah, so I think just to start off with setting an expectation, I suppose, that in accessing our services, what we would expect normally is that individuals who are using our services would make their own way and would have their own access to transport. But where that's not possible, we have designed systems to provide support. So when patients go outside of our area, for example, we always provide reimbursement and in some cases arrange journeys and try and coordinate that. In coming to our hospital services, we have arrangements in place through the individual services to arrange transport for people who've got routine appointments or things that they're not otherwise able to attend. Sorry, closer. So we have a range of services. We have our own patient transport service that we manage locally within the hospital. We also use a range of other providers as well where we need to do that, and we're constantly reviewing the service. In fact, we've got a transport review that we're actually undertaking at the moment, which is about looking at the shape and configuration of those services, what's available. But certainly there is an element, I suppose, which comes down to those individuals that are able to do so should be making their own way to our services, and that's just the design of the NHS, if you like. But in terms of anyone who's unable to do that, we have support mechanisms in place, and we can arrange transport or we can arrange reimbursement depending on the criteria that apply. It is different in individual services, so I'm not going to try and list them all off here, but broadly it's based upon trying to make sure that everybody's able to access the care that they need.
I suppose one of the underlying issues is inequality, and you clearly, and all of us clearly, want a fair outcome. The difficulty for us in a rural area is measuring deprivation. That's the standard way that they do it. And unfortunately, one of the problems is that the index of multiple deprivation hasn't been updated for a good many years. It won't be updated till 2026, late 2026. The other thing is area-based measures of deprivation don't really work in a rural area. 2/3 of our deprived people, I think, actually live outside our most deprived area. So that's a fundamental challenge to us in trying to identify people who might be more in need than others. So we're alert to it and we're working on trying to come up with different ways of identifying people who have higher need above and beyond their clinical need. This is about the circumstances and deprivation they find themselves in. Thanks.
Thanks for getting really great questions. So thank you for that. Any? Okay. Yes, please.
Just on the back of that. So to what extent in community transport, e.g. for the RBS, integrated into the NHS Borders transport provision, And how do costs compare with the continued reliance on taxis that the NHS borders use?
So that is a good question. First of all, we don't currently have arrangements in place with the Royal Voluntary Service. We have had that in the past, and as part of our transport review, we will explore that along with other community transport options that are available. So we're certainly not against working with any voluntary sector partners or otherwise. Our model is based upon providing the services that we need to do in-house as much as possible. We don't actually have a big reliance on taxis. We use taxis for individual journeys for particular people who are usually coming from locations where they're not well served by other transport connections, and it's normally around their individual need and what's most available for that. But I'm absolutely open to us, as part of our review, looking at all the options that are available, and I think we will engage with the Royal Voluntary Service and any other providers to make sure that we're looking at the best possible use of our resources and the best possible provision for our patients.
Thank you. Any other questions you'd like us to focus on? Hi.
I'd rather not stand up. With an aging population and a potential increase in multi-comorbidities, what are we looking at in relation to access for patients to, for example, outpatient services? The reason for my question is we have an elderly neighbour who was very grateful for being offered 4 different appointments to 4 different specialties, all in the space of a week. But from our geographical area, that added up to nearly 300 miles of travel in the space of a week. So I don't want to indicate that she wasn't grateful. She most certainly was, but I do wonder about whether there is something we could do to actually look at the outpatient requests that there or requirements that are for individual patients to maybe marry up appointments so that people are not travelling excessive distances, and which might sit very nicely with the green agenda as well.
Thank you. That does sound like an awful lot of miles travelled. I think Lynn's going to.
Yeah, thank you. As someone who used to live in Carlocks, I have lots of sympathy. I used to travel down as a registrar down to the borders. So yeah, absolutely recognise the journey that you're talking about. There are several underpinning principles to the clinical strategy, which I know we're referencing a lot, but is exactly the solution that we need to the problem that you describe. The first underpinning principle is that we're moving care closer to home. So Sarah described that, and that's about how we deliver care at home, as we've described, but also within communities. So how can we look at, rather than the BGH being the sort of centre of NHS borders, how can we look at how we deliver care in different ways? Now, some of that might be that we carry out clinics on a more peripheral place, for example, in Haylodge, which is a bit less. It's still, still travel, but it's a wee bit closer to home for yourself or for your neighbour rather. But also how we carry out virtual consultations as well, and how we support sort of virtual, whether that be by telephone or whether it be through other technology. I've been told off on multiple occasions for suggesting that the elderly are not very, very technologically able. And so, I think it's really important that we make sure that we're offering the right solution to people. The second really important fundamental principle in the clinical strategy is the concept of patient-centred care. So whilst we have guidelines and we have evidence base and we have all of the things that drive the delivery of medical care particularly, we also have people at the centre of everything that we deliver. And I think what's really, really critical here is that we're asking people what they want. So for example, and I don't know your neighbour's circumstances, but we have a little bit of a tendency as particularly a medical profession to say, I'm the doctor and I'm going to say this is what's going to happen next. And actually what we need to be doing is saying what's important to you. And that may well be for somebody who, you know, perhaps wouldn't be well enough for an intervention. I often speak to patients where they say, well, what's the point in me having that scan, doctor? You know, why would I have that scan when actually it's not going to change the outcome for me? And maybe I need to travel an hour and a half to have that scan, which actually is not going to change anything. On the other hand, they might say, well, if there's a possibility that I've got a cancer, even if I can't have treatment for that, I still want to know. And it's very, very important for me to know. And therefore, I'm prepared to travel the hour and a half to have that scan so that I know. And then it's adding value for that person. So I think this is about individualized care. It's about us seeing the person, not the condition. And that's absolutely one of the really key and critical underpinning principles to the way that we're going to deliver care moving forward. Now, we do that already and we do it well, but I think there's much more room for improvement.
Just to add to that, so thanks, Lynn. I think on Monday we actually discussed in our executive team about a proposal which Oliver's taking forward, which on the back of that is just looking at how we reshape and restructure the delivery of outpatients. I suppose I'd just go back to in the public health sphere, there's a guy called Sir Muir Gray, and he describes this concept where once people have finished work, your full-time job is to obviously keep yourself fit and independent. My immediate reflection on that is I didn't necessarily think that translates through to going to an outpatient appointment every day. I think clearly that has to be far more patient focused, as Lynn said, and I think it's really important that we start those conversations with people in the communities as soon as possible. Thanks.
Thank you. We are getting really excellent questions. Thank you very much for that. Still keen to hear more. Yes.
Sorry about this, it's Tracy again. It's obviously stimulating lots of thoughts in our heads. One of the things that we've not done for a while is the Good Neighbours scheme. And within the Good Neighbours scheme, it was part of helping people in the community to look after themselves and keep themselves well and encourage people at an early time to go to the GP and advocate and go with them so that they were chaperoned. Is there any possibility of that happening again, or is that just something that is just way off the scale?
Thanks. Thanks, Tracy. And don't apologise. That's exactly why we're here. So working again, when we talk about working with partners, so SPC run, which maybe we're resilient communities, is the approach that they run, which is exactly that, which is understanding who people are in the community who are frail, may well be like your neighbour that you described, and actually having an understanding of who they are. Primarily, if there's weather like today and there's flooding and there's adverse weather, we know where these people are, and we could ask people in the community to check in on them and make sure they're okay. Not everybody has a good neighbour. We've got to, you know, you obviously are, so that's fantastic. Lots of people have social isolation. We live in the borders. It's very rural, farm, cottages, middle of nowhere. So working with SPC around resilient communities and what we could bring, and particularly what the volunteer service can bring is key. I mean, in health and in the borders, we have a long-standing relationship with the volunteer service. Many, I shouldn't say this, Andrew Bonks, we're meant to buy our own coffee, but many coffees have seen many of us through from the front of the BGH, including if you're there for an appointment. So I think it's how we connect the system to itself, and how we use everything we possibly can to make sure we can keep people well at home.
Thanks, Tracy. Keep them coming.
For somebody who came to see the tapestry today, I feel I'm doing quite well for questions.
Well done.
I'm keen to know what what opportunities you think there are in relation to engaging with big national companies like Tesco's and Asda, etc., in relation to supporting the health of the population that they are very happy to take our money in relation to us buying our food from them. But what responsibilities do you think that they could engage with in relation to supporting with diabetic patients, for example, patients who need support and advice in relation to the diets they should be eating for health, for their weight, etc.?
I'm not sure how I've got the microphone to answer this one. Firstly, I think that's a really good question. I might bring Sahil in a minute. I'd go back firstly to our, I guess, the partnership strategy that we described at the start, and recognising that when it comes to the determinants of people's health, then clearly health services pay 20% or contribute 20% to that, but the environment that people live in, the services that they have access to, their access to income, etc., plays a disproportionately big impact. And I think we need to have some of those active conversations, because I think it is really important that we work closely with those organisations as an anchor institution, because it's as a health organisation, we will be in the borders and have been for a significant amount of time. And I think we obviously will play a significant part in what that future looks like. And I think we need to have some of those discussions and bring those out with conversations with the council, and then that gets into conversations around planning, etc. And you see in different areas, I'm not quite up to speed on where we are in this in Scotland, but lots of those local planning discussions are why public health was moved from health into local authority within the English system, and it's really to get more into those broader determinants of health. But I'll pass it across to Sahil to pick up on that as well.
It's a classic wicked problem, isn't it? Yeah, I suppose you kind of understand when I use the term wicked, it's not straightforward, and it's complex. I've got a member of my team who actually did work with Tesco in the past. So I think you make a good point. There's a population health framework that was produced, co-designed by COSLA, as well as the Directors of Public Health, that was released a couple of months ago, which talks, and the second priority is the obesogenic environment and how to address that. And there's a number of policies that will follow on, such as Good Food Nation. But I think what you're saying is, can we as a whole society work together to address the problems? And of course, the answer to that is yes, but the problem is that everyone in each of those organizations have got their own drivers. And obviously the one is around profit for these big supermarkets, but they do collect an awful lot of good data on what we have and what we buy and where we buy it. So I think potentially it is possible for us to build relationships with our local supermarkets. As I say, some members of my team have already done that in other places. I think that the experience has been they are a little bit wary about sharing their data, because of course, everybody's now aware that data is king and it's gold. So they're a lot less they're much more reluctant to let go of it. So working in partnership and working with our population is going to be key to get this done. So our relationship with our residents and their ability to manage. I know an awful lot of us worry that we've got an aging population. The way I look at it is we've got a huge asset base with lots of people with loads of lived experience that we should galvanize and use. And I know I've got elected members in SPC who are really keen to access the older population. Part of the work that I'm intending to do is to start to work with older communities to galvanize their activities to help their neighbours, and some of that will be around building a social movement to well-being and health, and that's how we solve some of these difficult problems. But it's not going to happen overnight, and it'll take a long time. Thanks.
I'll just add to that that the start point of our clinical strategy. So our clinical strategy asks really importantly 4 key questions about about the services that we offer, but the first one, and it's based on the feedback that we got from all of the contributors to our engagement event last January. The first question is, how do we as a health board help people keep themselves well? Everyone has that individual responsibility, and we obviously recognise that, but sometimes our services are more turned towards, I guess, to responding to ill health rather than helping us promote positive health. And I think there will be some significant opportunities over the next couple of years to really try and, I guess, drive that through the clinical strategy. But outside of the health board, I know obviously there's a completely cyclist answer. The Tour de France starts here in about 18 months. Well, not here, not Gala Shields. But it starts in, sorry? It would. Let's not have that in the press. It starts in Edinburgh and it's got to get to Carlisle somewhere. And whilst the route hasn't come out, I think we need to be really positive about using that whole agenda as something. How do we start to get more people active, get more people out involved in some of the fantastic physical environment that we've got around us? And I think that then changes the conversation and puts it in a more positive perspective. And I think that's going to be key to how we help everyone get the most out of their lives. Thanks.
At a danger of leaking a bit of our clinical strategy that colleagues might bash me on the head for doing, one of the strands of it is about aging well. And we have a very talented designer helping us illustrate this. Now, I am very much in the demographic of aging well, being over 65. But only just. But the illustration shows someone with a stick. So I would really like that changed. I'd like to see us aging well. I know she's not happy with that. But anyway, I look forward very much to sharing the full clinical strategy with you later, perhaps at our next event. So ladies and gentlemen, thank you all so much. I think it's been a great conversation. Thank you for coming, even if you came to see the tapestry, and it's great. Thank you for coming in, and thank you for the great questions. And we will be answering all of the questions that were submitted before on our website, as well as the ones that were raised today. So thank you all very much for coming, and enjoy the rest of the rather dreich day. Thank you.